Okay, so just while everybody is joining, I'll just make a start now. So thank you for attending today's ISBNPA webinar titled How to Recruit Patients with Advanced or Rare Cancers into Research Studies, particularly into physical activity or exercise research. The webinar today is presented by the Special Interest Group Cancer Prevention and Management. We have one speaker for today's webinar who I will introduce shortly. And the plan is to have 30 minutes for our speaker's presentation, 15 minutes for a Q&A, and then we will close today's webinar. And we have set up a hashtag for today's webinar, and the hashtag is in the top right-hand side of the screen. So it's just ISBNPA CPM. And it will be included on all of the introduction slides that I'll be presenting, just in case anyone wants to make a note of it if they plan on tweeting today. So I'm just going to give a very brief introduction to the webinar, and this will just cover some general housekeeping just before we move on to our speaker. Okay, so as part of ISBNPA, these webinars are organised as an extra service for our members, and these webinars are organised by the special interest groups of ISBNPA, and you can see a full list of the special interest groups and how to join them on the ISBNPA website, and the link to access that information is on the screen here. On the website, you'll also find information about webinars to come, and you'll also be able to access recordings of webinars that have been conducted in the past as well. So just to give you a brief overview of the Cancer Prevention and Management Special Interest Group, the aim of this group is to promote lifestyle interventions and behaviour change, and as part of this, it covers prevention, screening, early detection and lifestyle interventions for people living with and beyond cancer. The group also aims to develop a multidisciplinary international group of researchers who combine the expertise of relevant behavioural, physical activity and nutrition disciplines. And obviously all of these factors are important for informing policy, public health, and also for developing interventions as well. So just briefly, just to introduce ourselves, so our group is made up of the following executive team. Becca is the chair of the group and Cindy is the deputy chair. Linda is the immediate past chair to Becca and Zan is the treasurer for the group. Emily is the communications officer and Jordan is the social media officer, and I am the webinar officer for the group. We currently have a vacant role open for a secretary for our SIG and also other committee positions as well. So if anyone is interested in taking part, then please do get in touch. It will be great to hear from you. So I'm just going to move on to Becca, who will briefly discuss the Cancer SIG and the UK Society for Behavioural Medicine. So Becca, I'll just pass over to you.
Thanks, Hannah. So we jointly host these webinars as the ISBNPA Cancer SIG with the UKSBM Cancer SIG and also the Society for Behavioural Medicine Physical Activity Group. So for those of you who aren't aware, the UK Society for Behavioural Medicine is a network in the UK of academic and clinical health researchers who are interested in applying knowledge, theory and evidence on health-related behaviours to improve health and well-being of people in the UK and beyond. And the mission of our specific SIG is to provide a forum for the exchange of ideas, knowledge, information and best practice for those interested in the application of behavioural medicine to various aspects of cancer management and prevention. And this cuts across a number of behaviours, which includes diet and physical activity, and by working with relevant SIGs from other societies, such as SBM and ISBNPA, we're trying to raise the profile of behavioural science research within cancer research and also cancer research within behavioural science communities through events such as today's webinar. And we have our own hashtag, which is on this slide, and we also have now a group on LinkedIn. If anyone is interested in joining, please do so. Can I ask you to move on to the next slide, Hannah? Thank you. So this is the other SIG with which we co-host these webinars. So the Society of Behavioural Medicine's Physical Activity SIG, which our immediate past chair, Linda Trin, is very heavily involved with. And the mission of this Physical Activity SIG is very much focused on the latest initiatives relevant to the physical activity field. It provides another format for formal and informal networking among members who've got an interest in physical activity, and serves as a forum for advancing physical activity research through developing submissions for the Society of Behavioural Medicine conference, which I believe abstract submissions are open at the moment, and mentorship opportunities to junior members and dissemination of healthy living and public-facing articles, just to name a few of the things that they do. Thanks, Hannah.
That's great. Thank you so much, Becca. Okay, so for today's webinar, you will all be muted apart from the speakers and organisers, and this just helps us to prevent noise during the talks. If you do have any questions or comments for our speaker, then please either put your questions in the Q&A function or virtually raise your hand. But please bear in mind that we will only get round to questions after our speaker has finished his presentation. Okay, so the exciting bit. So moving on to today's speaker. Today we have a presentation from Associate Professor Nicolas Hart. Nicolas is an emerging leadership fellow in cancer survivorship, as well as the Programme Director of Clinical Exercise Physiology at the University of Technology in Sydney. His research focuses on improving outcomes for people with cancer, particularly those with advanced or metastatic cancer and those with supportive care issues. So I'm just going to stop sharing my slides, and I will pass over to Nicolas, who can begin his presentation. Nicolas, over to you.
You're muted, Nicolas.
I did the wonderful thing of making the worst mistake you could possibly do. Hello, everyone. Thank you very much for attending this webinar. It's my pleasure to be here to present on the topic of recruiting participants with advanced and metastatic cancer for rare cancers, which I know is quite a broad range of cancers to cover. So as we mentioned, I am from the University of Technology, Sydney, and the emphasis of my research has been on the advanced and metastatic cancer space. So before I go into the recruitment process, I was going to briefly highlight my background in the area, because it's going to inform some of the information that I give you today, and may also lead you towards some of the questions that you may wish to ask a bit later on. So from about 2015 onwards, I have been conducting clinical trials with patients who have advanced and metastatic cancer, and in particularly those either with bone metastases or even those at the end stage of life. By that I mean 34 months or so before they are due to decease. And these trials range from single-site trials through to multi-site trials, up to almost 18 clinical trial sites around the world. So I have run trials both in Perth, Western Australia, which is where I'm originally from, as well as across 3 states in Australia and then 8 countries around the world. And through these, we had to recruit patients, or didn't have to, we wished to recruit patients for our clinical trials, which were supervised exercise studies. They also had behavioural change theory components to them that tapered people to self-management, and also had some trials that were telehealth trials or remotely delivered exercise trials to these people. Some of them ranged from 12 weeks, which is seemingly quite typical in the exercise oncology space, but some of these trials were 2-year trials. And so you can imagine recruiting a participant to research in our field for 12 weeks is one thing. To convince gently a participant to wish to participate in our trials over a 24-month period is a very different proposition. And so there'll be some lessons along the way that I can share with you, but I do highly suspect that there will be a common theme across any population you try to recruit for a clinical trial. And I just wanted to acknowledge those. Furthermore, outside of the exercise realm, I have also been doing a lot of other research in the advanced and metastatic cancer space. The reason why I highlight this is because obviously I'm passionate about advanced and metastatic cancers as well as rare cancers, because these people are largely underserved both in supportive care research and clearly in exercise research. They are very much an underserved, appreciated population because of the complexities around them and a lack of knowledge around what the appropriate exercise prescription is for these people. So I just wanted to, I guess, acknowledge that, because some of the principles of care in the bottom right-hand corner directly go to some of the issues that I'll discuss around recruitment and support of people with advanced cancer following completion of research trials as well later on. So lastly, I guess I wanted to say that this all culminated into a set of guidelines. And so some of the work that I've done in advanced and metastatic cancer, recruiting patients and delivering exercise to these high-risk populations has led to some clinical guidelines, which I am just bringing to your attention because there's a lot of work. And they're also fantastic guidelines that you should study. But these go to the safety and feasibility and efficacy of delivering exercise in this population, that these guidelines would not have been achievable if myself and many of my colleagues around the world didn't decide to dare to be different and go for these high-risk advanced populations. And the reason why, by and large, these people were excluded from exercise historically is because clinicians did not want to refer patients with advanced cancer. And I will get to that very somber point very shortly. So lastly, I guess I have spoken about advanced and metastatic cancers. I am also involved in delivering research trials in the rare cancer space, which is also going to be a topic we're touching on today, around multiple myeloma, which some of my colleagues may or may not be on this in this webinar as we speak, but also neuroendocrine tumors as well. And so there's a remarkably diverse range of people with cancer in neuroendocrine tumors, very different areas affected, very different symptomology, very different barriers of entry, very different interventions required. And so that in its own right shows you the nuance, particularly with rare cancers, as to some of the challenges we face to inform potential participants about research, to encourage them to then join research in this area. So before we get into the actual information around recruitment, what are the barriers, what are the facilitators, and how do we go about it, it's probably important to start on some terminology basis, because advanced cancer in the hematological malignancy space is not in the same paradigm as, say, a solid tumor, which is quite obviously a stage 4 metastatic cancer. And so advanced cancers typically are solid or hematological malignancies that are considered treatable, but are not considered curable. And so a large proportion of hematological malignancies will fall into that space, unfortunately. Metastatic cancer, as I mentioned, is stage 4 cancer, almost always advanced. Testicular cancer is one example of a metastatic cancer that is judged to be curable. So as a result, won't technically be advanced based on the earlier definition. But it's important to note that people with advanced metastatic cancer are not a simple group to involve in research, and particularly to involve in exercise and physical activity-based research, because they have varied disease trajectories. They have various times with stability of disease, various levels of disease progression, various levels of mono or combination or sequential therapies, and various levels of predictability around how they will respond to their therapy and how they will perform in exercise. And so it's obvious that it can be quite a challenging population to design effective, safe and feasible exercise programs for. Similarly, with rare cancers, for whatever reason, the USA seems to have a slightly different definition of what a rare cancer is. The USA seems to have a different way of approaching many things. So that's probably not unusual. But typically the overarching definition that seems to be mostly accepted around the world is that a rare cancer is an incidence rate of less than 6 cases per 100,000 people per annum. And as you can see here, rare cancers, when you combine or pool all the types of different rare cancers in the world, still only represent 22% of all cancer diagnoses and account for 27% of all cancer-related deaths in Australia. You can imagine, if that's all of the different types of rare cancers pulled together, that if we are targeting one type of rare cancer for an exercise trial, recruitment becomes even more paramount, because every single patient is worth their weight in gold when it comes to trying to deliver a feasible and statistically appropriate research trial. And so, as I say, rare cancers and advanced and metastatic cancers have some parallels, but they are not mutually exclusive. And by that I mean you can have a rare cancer that is also in the advanced category as well. So they can be either one. So how are people with advanced and metastatic cancer, and I'll extend this to rare cancer, different to everyone else? Some people might think we know how are they really different. We're still prescribing exercise, but they have very different motivators and very different barriers. And this is because of their stage of life and their stage of disease trajectory. So they'll likely have different supportive care needs, different cancer treatment needs, different life goals. So they obviously may have almost certainly have an abbreviated life trajectory where they may have different aspirations around holidays, time with family, and other competing interests that take higher priority over what we do. And so is it incumbent on us to be able to educate them on the genuine benefits of a research trial, in particular around exercise, to try and engage their interest and to join the study. But it also features into how we design our research studies, what level of tolerance or capacity to be flexible in our research design to facilitate some of their life goals and clinical needs within their cancer trajectory. So I just wanted to highlight that there is a very clear distinction and difference between them and, say, people who are palliative at the end, like very end stage of life, versus those who clearly have localized disease and incurable intent. So probably the most stark characteristic, and I did a literature search over the weekend to prepare these slides, and it was quite surprising to me how low the number of adults with cancer are that enroll in any clinical trial related to cancer. So this is your drug trials, physical activity, exercise, nutrition, anything. Only on balance, 5% of people with cancer in the adult world will enroll in a clinical trial. In one sense, that's not overly surprising because of the sheer volume of people with cancer living in the world. We're not going to reach them all with research, but it's still a very a profound figure to say how low that is. And that's because of a range of factors. Obviously, if 5% is all treatments, you can imagine physical activity and exercise trials would be even lower, or much lower than that. And of course, if you then look at the other side of it, people with advanced and metastatic cancers or rare cancers who have even less funding available from philanthropy or government sources are likely going to be even more marginalised. And that's sort of why I guess my passion is focusing on these marginalised subpopulations that really need our support and our care. Now, as I say here, the reasons are multifactorial behind why participation in cancer trials is low. The literature would tell you that it's very much patient-centric because most of the literature seems to focus on the reasons why patients are not declining participation and the barriers that patients face. But of course, that is just one side of the coin, not even a coin. There's multiple sides to whatever shape you want to consider. And so there needs to be a broader approach to what considerations we can have as researchers and as clinicians to be able to facilitate better access to clinical trials for people in general, but especially in the exercise and physical activity realm. So of course, as I said, it's not patient-centric. There's multifactorial contributors to recruitment outcomes and to engaging people into clinical trials. Chief among them is the clinical trial design. It needs to be fit for purpose. It needs to suit, the outcome you want to achieve, but it needs to also really be a person-centered type trial to facilitate the type of challenges that these people will face, whilst hopefully delivering on the endpoint. Now, of course, there's a lot of caveats in this, but nevertheless, if we're trying to optimize recruitment and we're trying to facilitate the best way forward, trial design is paramount. Of course, there are patient factors, as in personal, individual factors around the patient, their clinical condition, their own personal views, biases, and fears. There's also the clinicians, and of course, we love our clinicians, but they do have a bias against the value of physical activity and exercise, and where it is prioritized amongst drug trials, for example, or other areas that they might prioritize above physical activity and also above clinical trials in general. So there are some clinician factors that I'll go through briefly. And then there's obviously system level factors that which supports the clinician, the patient, and clinical trial design. There are also barriers that we need to consider. So I'm going to talk about all of these because recruitment is not as simple as put up a flyer and recruit someone and hope for the best. There's obviously a consenting process and all other factors to consider. So before I do, obviously I wanted to highlight that the vast majority of evidence over the last number of years, some of you may remember this slide from ISBNPA this year, there's been a wealth of research that has rapidly generated over the last 20 years, but obviously over the last 30 or 40 years is really when this field was born. And even to this day, relatively speaking to most other research trials or epidemiological studies or anything else around physical activity and exercise as distinct factors, advanced and metastatic cancer is still quite rare. No pun intended to the topic of the conversation, but advanced and metastatic cancer is still quite scarce or rare within the research context. And so the evidence is still building there, and it's still in its relative infancy. But you can imagine rare cancers are even less researched. I think multiple myeloma might even be one of the more substantive clinical trials populations in the rare cancer space in exercise to date. So there needs to be a lot more focus on that going forward, because some of the recruitment challenges we face now will be the information that we provide to participants and clinicians, but we don't really have a lot of evidence right now to be able to give a level of assurance to these people. So as I say, despite the strong clinical need for people with advanced metastatic or rare cancers to be able to be involved in supportive care and survivorship trial studies, they're often excluded, in particular with the exercise oncology studies. Now, the reason why they typically excluded is because they're often prioritized, often due to the lack of curative intent treatment, to drug trials to try and control disease or to get the 1 in a million shot of a new curative drug. And so clinicians would typically prioritize drug trials ahead of supportive care trials and especially ahead of exercise and college trials. I say that because most people who are controlled have a level of disease control with advanced metastatic cancer are likely on treatment and are likely on a sequencing of treatment and are likely going to be available for drug trials, because there are a lot of drug trials in the advanced and metastatic space that we're competing with, more so than obviously in the curative intent stage. There's also a defeatist attitude by, and I clearly do say some clinicians. What I found quite appalling in my time working in advanced and metastatic cancer space is the genuine comfort of some clinicians to willingly and openly declare that they don't see the point in providing clinical trials for supportive care in advanced and metastatic patients, which is an appalling attitude to have. But that's because they view that their lifespan is so short. Why put them through a clinical trial? Why put the resources in a resource-limited setting into these people? Allow them to just go and live their life and we'll keep them comfortable. Of course, I think that's an appalling attitude to have, and I think that they deserve to be involved in research trials, but that is some of the attitudes that we are confronted with in some pockets of the oncology hematology world. So the other aspect, of course, is that people with advanced metastatic or rare cancers have an added complexity to the trial design and delivery, because there's a lot more barriers, there's a lot more clinical features to consider, there's a lot more treatment factors to consider, there's a lot more personal factors to consider. And so it can sometimes be a challenge to design the correct trial for these people. And so, of course, what you should always do, and I know that this is one of those things that gets raised at ISBNPA every year, at least at the conference that I was just at in Sweden, and it is something that is heavily raised across the research landscape these days, but of course is the concept of co-design. It's imperative. You should definitely be co-designing clinical trials with these people, because we don't have all the answers, and we need to be able to design a trial that's fit for purpose with these people. And so, as I say, it's got what consumers often say, or patient advocates always say, is nothing about us without us. And that is obviously to involve them from the beginning, purposeful planning, consultation, education, information, and knowledge with people with lived experience, as well as understanding what outcomes matter to them. So there's obviously a range of stakeholders I've listed. Could have more stakeholders, but nevertheless, I think it's a very important component. And so when you get the clinical trial design, take your time to do it right. If you rush it, you might end up inadvertently creating barriers and problems with the trial moving forward. So obviously, as I say before, the clinical trial type may be one of the barriers of entry, because you may have a clinical trial that's not suitable or not easily accessible, or not suitable for the population you're dealing with. And in that regard, I sort of use rare cancers as a prime example. Rare cancer, if you want to get to a particular statistical level to prove it's a particular objective outcome that might be physiological, you might need a sample size that's going to be awfully complicated to be able to achieve in a rare cancer population. That doesn't mean you shouldn't recruit and try and do that study, but you might need to consider alternate ways of how you might structure a trial. So you may have a self-controlled trial where you may have the same population acting as their own control. You might have a preceding control period before they then go through an intervention, before they're then followed up. There may be a range of different opportunities. There's one of the other issues, I guess, with regards to trial type when it comes to advanced and metastatic cancers, as an example, is that you might not be able to do a crossover. You might not be able to have a wait list, because these people are going to, unfortunately, very likely, lose their lives. So some options are not simply available to you. And so these are all those sort of sub-factors that you need to consider when you're designing trials. Obviously, you have your phase 1 to phase 4 clinical trials that could be considered. I have listed there adaptive, pragmatic, and smart trials. I have been involved in a pragmatic RCT before, but not an adaptive or smart trial. But these are some alternate, quite flexible study types that might be useful when you're trying to explore different research questions with a rare cancer population, for example, that you might struggle to recruit for, but have multiple efficacy questions around the suitability of an intervention, for example, and whether it needs to be de-escalated or escalated in a particular way. And of course, with a rare cancer in particular, consideration of single versus multi-center studies. Obviously, multi-center studies are more beneficial in the sense that rare cancers are complicated to recruit for. The challenge, of course, is that the reliability, consistency of delivery of intervention, and so forth may then become more complicated to maintain, because you'll have multiple different people delivering an intervention over multiple cities or states or sites. And the other aspect is, the more sites you have, my suggestion would be reduce the number of measures you take, because the more sites you have and the more measures you have, the most likely you're going to have issues that develop over time with regards to the feasibility of running the study in the first place. So, of course, as I mentioned, the clinical trial design is one thing. There's also a dilemma around the intervention. So people who are with advanced and metastatic cancer, as I said before, they might be on chemotherapy. They might be receiving palliative radiation therapy for bone pain or for somewhat other reason. They might be commencing immunotherapy. And this will happen almost certainly while they're on study. It's very difficult to have a nice, clean, simple, highly controlled clinical trial in this advanced and metastatic space. And so we need to be able to accommodate a flexible trial design or a flexible intervention that can better accommodate the fluctuating condition of participants. Now, of course, that may depend on the purpose of your study. If you're doing a dose response study, you would definitely want to have built into the design a way to make up for the lost time and intervention later, which I'll discuss shortly. But if it's a feasibility or a safety study or a behavior change study, then you may have less requirement to be as specific around modulating the program to better support these people. But it is certainly something to be cognizant of. And if dose response is your target, which for a lot of physiological endpoints it would be, autoregulation is a very common feature in clinical trials these days, where essentially if you downgrade, so lower the intensity, lower the volume, or they miss sessions, they obviously will either increase volume or intensity in subsequent sessions on top of their predetermined program, or include make-up sessions, or add an additional couple of weeks at the end of their intervention period to try and make up for it. But those are just some of the factors around, I guess, intervention that you need to be considerate of. But I think that the biggest challenge for recruiting for advanced metastatic and rare clinical trials is this dilemma of the controller, because patients in this area of disease are aware of their impending mortality. They're aware of their limited options available to them. They're aware of many of these factors. What we're providing to them, even with a clinical trial and a control arm, is a sense of difference and a sense of potential hope, even though we cannot promise anything in a clinical trial. And it's almost an expectation these days that patients are provided with something more than the usual, even in the control arm. Because if they're randomized to the control arm and they get nothing but the status quo, even with the best intentions and the greatest level of altruism, they will likely withdraw at some point. And we need to retain our participants in the control arm as well as the intervention arm if we are going to try and have an adequately structured clinical trial if an RCP is the trial design of choice. The other aspect, of course, is that physical activity and exercise becoming so well established as a beneficial intervention or a beneficial healthcare therapy for people with cancer, that it's almost now this tightrope of, is it now unethical for us to literally request they don't in the control arm simply because we know it's beneficial, and are we going to willingly abstain even a basic level of physical activity? So of course what we usually do is say participate in what you usually do, but then that's still no different to the status quo. And so a consideration for retaining patients, because recruiting is one thing, retaining is another, is to obviously consider what you might do with the control arm in a situation like this. And some of those considerations might be, what is the primary endpoint you're aspiring to? So in one of our myeloma trials that myself and some colleagues are running, bone is the bone retention is the primary endpoint. So if we could give the control arm balance exercises, something that's not going to be highly osteogenic, but something that they will receive a benefit from, but that it will not contaminate or disrupt the primary endpoint of the study. And because it's a rare cancer that we're dealing with, we need to consider those options to be able to recruit and retain patients. And so I think we just need to start considering that, because print materials, yes, we all give our control arm print materials with recommendations. We know full well they're not going to follow them. But perhaps it's my level of guilt these days, but I feel guilty that we know they're not really going to adhere to those print guidelines. Can we give them something else that won't disrupt the fidelity between intervention and control, but allow them to feel like they're receiving something? And so that's just another factor of consideration from a clinical trial design factor. And lastly, I'll go through these quite quickly, but of course, several of our clinical trials, so GAP4, which presented at ISBNPA, we had an extensive list of clinical eligibility criteria that made it ridiculously absurd to be able to recruit participants into our trial for advanced prostate cancer. And we did that because we designed it like a drug trial, because we were looking for overall survival as the endpoint. The issue is that the clinicians who are referring participants to the trial, and even the research coordinators who are not necessarily adept to the particular cancer in question, are not necessarily going to be able to accurately or appropriately include or exclude patients on a whim if there's a highly complex list of inclusion-exclusion criteria. They're also very stretched and very busy, and so it makes it really complicated for them to naturally and simply screen participants. And so if we want to increase the ability to include advanced metastatic or in particular rare cancers, we need to consider the must-have versus the nice-to-have for clinical eligibility criteria. And the same goes for all of your other ancillary inclusion-exclusion criteria as well. And what I've said there is ensure you have the right people to evaluate the criteria. The oncologist and hematologist is not always the best person to be able to evaluate the readiness of someone to exercise. They also might not be the right people to evaluate the suitability of someone through whether they've got musculoskeletal pain or otherwise to exercise. I would argue the exercise professional is a better place for that, because we do not ask oncologists or tell oncologists how to supply chemotherapy. So I may be political and controversial, but I very strongly believe that sometimes patients are inappropriately excluded from trials from poor decision making, as opposed to allowing a participant a right to self-determination and without bringing the right people into the conversation. The other aspect, of course, is inflexible delivery options. We have to consider in-person versus remote versus in a hospital versus in a community clinic to try and increase accessibility to what we do. And of course, we need to consider the burden of measures. So some people, particularly with rare cancers, think, well, we've got these people, they're really hard to recruit, let's get everything out of them we can. But actually, that's the worst thing you can possibly do because it lowers the quality of all the measures, lowers the quality of the study, and overburdens a participant or a patient who's likely already receiving a high burden of clinical care because of their cancer. So just stuff to consider there. Of course, the other thing is to avoid excessive number of site visits because there is not just financial toxicity, but there's a time toxicity to these people. If they've got a limited lifespan, they do not want to be spending it with us. As much as we love ourselves, they do not want to spend the rest of their life with us. We need to consider how we can better support them in a clinical trial and streamline their visits. And of course, there's a format of measurement. Please offer alternative modes and methods, particularly those who are technologically illiterate, might not be able to deal with digital resources. And because they're going through cancer treatment, they might have cancer-related cognitive impairment and other factors where they might need to sit, digest, interpret, and complete patient-reported outcome or experience measures. So you just need to be cognizant of everything else going on in their life, because we're not everything. So of course, there are also patient factors. So patients need to be educated. There's obviously some patients might have a lack of trust and be afraid of the experimental nature of research. They might lack understanding about what research is and what the physical activity and exercise process is. And they might have uncertainty in cases where clinical trials are randomized. And I say unblinded, but it's very challenging to blind an exercise trial. It's usually a single-blinded study. But patients are usually afraid to enroll in clinical trials more broadly because they lack the education and the health literacy to be able to appreciate what we're doing, how we're providing it, how it might complement their care, even in the control arm, because we know that people who are randomized control arm typically still receive better care because they have closer monitoring and closer contact to a diverse range of people. And so the other thing, as I said before, is does the trial offer treatment in all arms of the study, particularly in the curable space, and might be where it's suitable for a smart trial design, as I mentioned before. We might also want to consider that if we wanted to reduce the loss to follow-up from a control arm perspective, are there trials where we can consider different ratios of randomization from intervention to control? And the other aspect is the step-branch cluster RCT could be an interesting way to be able to capture participants without the risk of knowing whether they'll go into a control or intervention, because unfortunately we will know whether they'll be in a control or intervention at the time of recruitment. The other aspect here I wanted to acknowledge, I guess, is that low socioeconomic status seems to be a predictor for poor engagement and uptake to clinical trials. And of course, culturally and linguistically diverse people are sometimes excluded from clinical trials because they might not be as fluent in English as we would like. Of course, there is a bit of an ethical dilemma sometimes with the cold community, because to what level do you allow a family member or a caregiver or a friend who might be fluent in English and the other language to interpret for? Because there might be a level of undue influence or coercive control that we're just simply not aware of and we can't manage. And so then obviously that's just a dilemma. I don't have an answer for it realistically, because a hospital might have its own translation service that can assist. But I do certainly think that we should try to involve our culturally and linguistically diverse people more in clinical trials rather than taking the easy route and just doing English-only trials. It's just my little soapbox moment. But the other thing to consider is that people with advanced and metastatic cancer, we need to be considerate of the motivations that they have for being in a clinical trial. I've found in my own experience that people with advanced metastatic or rare cancer are actually relatively easy to convince to recruit to a clinical trial, because they are, as it says here, they sense that they've got nothing to lose. They're looking for anything and everything. And as a result, they are less selective about what's offered to them, and typically will engage in a clinical trial. I do say that they should have a right to self-determination, because I do have a bugbear, and I've had this experience where clinicians try to select the trial that the patient should go on and withhold certain trials from participants or patients to try and guide them towards a particular option. And I don't think it's appropriate. I think patients should have the right to self-determination, regardless of the clinician's belief of whether physical activity is beneficial or not. So, of course, one of the really valuable points that we need to discuss with participants is the option of, not the option, the concept of equipoise. And the reason why I say this is so that we don't lose patients if they're randomized to the control arm. They need to appreciate that actually the intervention, while to our best efforts we think it will be effective, we can't say that for certainty. That's the whole premise of the study. And so we need to highlight to the patient participants during the consenting process that there is this idea of equipoise, that there is no one better intervention than the control, because that's the purpose of the clinical trial. And we can't promise that they'll get a benefit from being in the intervention. And so hopefully that will alleviate their stress and anxiety if they're randomized to a control arm. And so it's really one of those things that if you explain to the patients around the idea of equipoise, they're usually a little bit more comfortable if they're randomized to the control arm. And as I say, it is complicated with poor prognosis cancers, and we can consider alternate ways to factor in control arm strategies to retain them. So the other thing is obviously is that we need to inform patients of the benefits of exercise in a general sense if we want them to be able to commit to an exercise program. This means the right people getting the right information at the right time. This means we should be having ourselves as exercise professionals having the conversation with the participants. Or if someone is doing it for us, they need to be educated on how exercise can overcome fatigue, manage pain, is safe and beneficial, provides a level of fitness and function. Because otherwise, if a clinician does it, I've seen many cases where a clinician will exclude a participant because they're experiencing pain, or a patient will exclude themselves because they're experiencing pain and they think that what we will do will make it worse, when actually, more often than not, it will make it better. So I will not go through this thorough list of tables, except to say that there was a wonderful paper published by my colleagues over in Queensland, which has recently been published as much of a month ago, I think, and actually explicitly looks at the barriers, facilitators, perceptions, and preferences of physical activity and participation between cancer types and treatment stages. And I would argue that none of these really surprise you, that large physiological barriers are treatment-related and disease-related side effects. Large barriers for your psychosocial is low mood, low self-efficacy, low motivation. And of course, the facilitators have tailored and appropriate accessible services and so on and so forth. And so you can see, and I'll allow you to digest that paper another time, I guess, is that the barriers and facilitators you see here are common across cancers. They're common across localized to advanced to metastatic to rare. And there's only so much we can do, but there are factors around what we can try to address when we're designing clinical trials to be able to better recruit patients and participants in this type of work. So the other thing is, of course, try to facilitate people joining exercise and physical activity studies is to engage their support networks. If you can involve family, friends, caregivers in the community, that's more likely going to yield a positive outcome. If you offer different types of training environments, not everyone likes to exercise in a group, and not everyone likes to exercise alone. So you can offer different programs, whether it's group or individualized, in person or remote. Enable other forms of exercise support, so maybe consider dyadic training programs, which allow the partner or the spouse to physically exercise along with their spouse. And of course, consider peer-to-peer support programs as well. But it's important that in your clinical trial designs where funding is available to try and address cost barriers such as time, distance, and other things. So cover membership fees, parking or public transportation, and locate facilities nearby people. Reduce travel, reduce time, reduce cost, basically, wherever possible. So I guess with clinician factors, and I'll try to go through these relatively quickly in the next few minutes, is that the heavy patient loads are typically cited as a reason why a clinician will not have the adequate time to be able to participate. They assume that participation may contribute to undue hardship, stress, and anxiety to a participant, and therefore might not even offer clinical trials to people to begin with. As I said before, they may engage in selection bias. They might choose their own studies over an exercise trial. They might choose their own implicit biases towards a drug trial than an exercise trial. They shouldn't be allowed to do that. There's also an over-reliance on physicians to recruit and enroll patients, which is why we should try to take on some of that responsibility and offer them co-authorship if it's a motivator for a clinician to physically get involved. And obviously your trial and recruitment reimbursement strategies are also an assisting factor. So again, clinicians may not value physical activity exercise. They may feel it is risky or unsafe. So we need to be able to educate clinicians. We need to be able to demonstrate safety and feasibility and reassure them that their patient will be well looked after. And so as a result, if we engage clinical allies around a clinician, we can help take some of the stress responsibility biases out of their decision-making process and help streamline recruitment and access to these patients. And this is where I think cancer nurses and allied health professionals are very highly valuable in the hospital and healthcare setting. So just lastly, I guess one of the challenges we face with clinicians and their recruitment to clinical trials is that they don't understand what their role and responsibility is on how to identify participants and their suitability to evaluate participants' readiness to be involved in diet and exercise clinical trials and outcome and programs in general, even in community. And so I think that there needs to be a big education piece around this when you are setting up your clinical trials to engage participants. I just highlight this because my PhD student, now postdoc, I've conducted quite an extensive piece of work around this to do with medical and nursing professionals and what the barriers are to getting them to actually refer people to clinical trials or to community-based programs. So that's a paper, a resource that you guys can read. I won't go through each individual item. And so for system-related factors, obviously that there's a range. There's structural, clinical, physician and patient factors around how they are engaged with during various clinic visits. But of course, one of the system-level factors that I find an issue is that clinical trials are not readily advertised and available for all patients to decipher, deliberate over, pick, choose, and understand. They're only offered what they're told by a select few people. There really should be a catalogue of clinical trials available at a clinical site that a patient can self-select, in my view, or at least inquire about, so that it removes any of those gatekeeping activities that can occur and allows person-centered care to truly be person-centered and to allow participants to really have control over the types of clinical trials they would like to be in. And if they preference a physical activity exercise trial, the clinician should really facilitate that. One of the other factors, I guess, is that, or I've already mentioned that they should ensure that all people are informed in clinical trials. Obviously, there should be an overcoming of bias against supportive care clinical trials for people with metastatic and advanced cancers. They do need to be run. They are worth the resources. They are worth the money. They are worth the time. They are people. We should also support people with advanced and metastatic cancers back into the community and clinical care after they finish their trials. That does not happen enough. And of course, one of the system level barriers is providing researchers, clinicians, and patients with enough space, resourcing, and infrastructure to be able to provide their clinical trials. And obviously, one of the issues is sometimes a lack of or disinterest of the administrative and hospital staff to support clinical trial, which may be due to a lack of knowledge, research, and education. So here is an example of, just very quickly, of creating multiple satellite sites across the entire state to be able to reach a large number of patients for clinical exercise whilst having one centre of testing. We had our testing centre in Perth, Western Australia, 40 minutes north of the CBD. We had people travelling 1.5 hours for testing, but we made sure we had exercise facilities local to where they lived, where our exercise professionals went and drove out to them, because obviously we wanted to reduce those barriers. Because speaking about system and patient level barriers earlier, this is one of those examples where you can try to set up the infrastructure and the geography to benefit the patient, because they are going through enough as it is, and we should be doing our best to support them. So lucky last, pretty much, or one of the last 2 or 3 slides, is that obviously we need to be able to increase awareness and reach beyond just researchers in clinical trial, to reach rare cancer patients, to reach people with advanced and metastatic cancer. We should be engaging their cancer organisations and advocacy agencies, because these people know their cancer survivors and caregivers. They have frequent interactions with them. They also know a lot about the disease and a lot about what people will and won't tolerate and what people will and won't be interested in, and they can be your best partners in being able to disseminate information and knowledge about trials and recruitment. And so I'm very strongly of the view that you should be engaging them, not just for trial design and recruitment, but also for knowledge translation and implementation thereafter. So this is the very last slide. I've got through it, but effectively I just wanted to highlight that, of course, the BMC series is a partner of ISBNPA. I know that BMC has got its own, ISBNPA has its own journal, but I'm going to plug a separate journal. So BMC Cancer, there is a special edition on diet and physical activity during and after cancer treatment. There is a sub-focus on advanced metastatic and rare cancers. And I would welcome you to submit any submissions, as I am a guest editor and I'm selfish and I wanted to advertise that. So, yep, that is me. I will hand over to the moderators for questions. My email address is also on screen and my Twitter handle if you would like to get in contact with me at any point in time. Thank you very much.
That was great. Thank you so much, Nick. So we've probably got a couple of minutes for questions. So if anyone does have any questions, then either pop them in the chat function or use the Q&A function and we can go through those. Just while I wait to see if anybody does have any questions, I noticed a few sort of key papers on your slides, and you mentioned about the guidelines that yourself and your colleagues had developed as well. Are there any other sort of key research papers that you think might be useful for people to read if they wanted to read a bit more, I guess, in detail around this subject area?
It's a great question. I mean, specific to recruitment, I'm not sure. I mean, there was one paper in the presentation that has just been published, was a rapid review, systematic review. Will certainly have all of the barriers and facilitators and other considerations that people would wish to have if they wanted to optimize recruitment. By way of the actual patient populations and exercise trials and even any clinical discourse that you might need to be aware of, nothing springs immediately to mind. There has been a recent multiple myeloma paper published by my colleagues at UQ at the moment, which will result from their multiple myeloma exercise trial. And I know that there are our colleagues in the UK, and I've forgotten what their study is. But if people email me, I actually do have some studies that I might be able to provide that at least will address, say, multiple myeloma, and certainly the advanced metastatic space. But it is, I would have to send through a list, basically. I wouldn't have it readily offhand.
No, that's great. Thank you. I've just put your email address as well in the chat function, just so people can use that if they do have any questions. One of the things as well I thought was really interesting was that, and concerning, was that clinicians, don't see the point in offering supportive care interventions to patients with metastatic disease, because they don't see the benefit. And I imagine that's something that's probably quite prevalent even now with some of the work that you're doing.
Absolutely. So it's because some of them, you do get some clinicians who are evangelically converted to the benefit of exercise, and we of course love them, but they're so far and few between. But yeah, it's quite shocking. I mean, clinicians that look after patients with rare cancers are usually far more open to the role of exercise and supportive care in cancer, recognizing people with rare cancers get offered relatively few things because there's not much funding for them. But it is, with the advanced and metastatic space, it's just a range of reasons. Some clinicians don't believe that it's worthwhile or valuable, but many just don't get what we do and are afraid that the participants may get injured or it may be detracting to their clinical care. And sometimes they think that it will be overburdensome. But this is where I think I obviously have a very strong view on the right to self-determination in your healthcare. I mean, I've had a clinician lodge a complaint against me because she wanted her patient to enroll in her clinical trials, which were a drug trial. The patient chose to exercise. The patient chose to enroll in our study and not hers. And she tried to accuse us of poaching her patient, basically, instead of recognizing that the patient actually does have a right to self-determination and a right to choose which study they would like to enroll in. Of course, the complaint got nowhere, but that just goes to show you how some clinicians will genuinely gatekeep to service their own clinical research agenda, as opposed to maybe the broader picture of looking after these patients. But yeah, it's definitely concerning.
Yeah, and I guess a lot can be said there about education, not just for patients, but also for clinicians as well.
Strongly for clinicians, I think, and most of them are quite receptive. But I think one of the challenges we face is because we're not built in a lab, and because people think that physical activity exercise is this abstract thing of, oh, just go for a walk and then you've done your thing, or sometimes they don't really quite get that there is truly a dose response, that you can have different forms of structured exercise that influence different biological systems, that have genuine benefits to cancer biology, treatment completion. And as you say, all of those other things, that a bit of education would go a long way. It really should be built into the medical curricula of some sort if you are becoming an oncologist, or even just doing medicine in general, that exercise is a real thing that has real benefit, as does dietitians and dietetics as well. But I feel like there's probably been a lot of people that have said that before me. I don't see the curriculum changing anytime soon. So,
Anna, sorry, just to interrupt. I've just had a message to say that the chat, when you popped the email in the chat, it hasn't, it's not visible to everyone. But I think, and there is now a question in the Q&A, but I think we can share that. There we go. Thanks, Nick.
Yeah, I'll just put it back on screen for a while. It's all right.
Everyone should be able to see that in the chat function as well now. So the question we have from Helen Crank is, do you always offer sessions or service based on condition or stage, so metastatic versus primary, specific rather than symptom specific?
It's a fantastic question. I've always, in my situation, categorized the exercise programs I do by the subpopulation as opposed to the symptom. But I very much agree that there is a very big space for doing it by condition, or symptom, I should say, as well. And I say that because obviously you might have a range of people with peripheral neuropathy of various levels, and it may actually be easier to mass manage people in an ironic way if you are dealing with the same symptomology. But likewise, obviously there are fatigue clinics out there to address cancer-related fatigue, for example. So it makes sense that you could do it based on treatment type, based on symptomology, or based on disease profile. I've just personally always done it by disease profile, but that doesn't mean, it doesn't make it better. It's just how I've always done it. So.
Okay, that's great, thank you. So we're just coming up to the hour now, so I can't see any more questions, so I just want to say thank you again to Nicolas for your talk this morning. It's been really, really helpful, and it's given us a lot of food for thought, I think, that we'll take forward with us in the research that we do. Yeah, and we've just got a thank you from Helen as well. So like Nicolas has said, he's happy for anyone to contact him if they do have any questions. But yeah, we just want to say a real thanks again. It was great to hear from you today.
No worries, and I'm sorry I almost went over time, but I was aware of it, so it's all right.
No, that's okay. Don't worry at all. Oh, well, thank you so much, everyone. Thank you. Bye now.